Hi guys, welcome back to my channel. Today I'm going to be filming for you a much requested video. This is actually one that I've been meaning to sit down and film for some time now, and I kind of feel like I've put it off a little bit, but not intentionally and not because I don't want to film it, but just because I've had other videos to film in the meantime and I kind of need to put them before this one. But now I'm really excited to be filming this for you. So essentially, as you can tell by the title, this is my sort of intensive care nursing video, kind of just to inform you guys what I do on a day-to-day basis, a little bit more information behind it. And for any of you out there who've asked because you're curious about working in ITU yourselves and things like that, I thought I would put this video together. I've kind of got like a selection of things, criteria in front of me that I'm going to go through just to kind of fill you in on some information and stuff like that, and kind of just briefly answer all the questions that have kind of been asked to me over the last few months, but I haven't got around to answering. So I really wanted to do like just one pure video about intensive care nursing, because obviously this is my speciality, this is what I kind of do. I absolutely love my job, if you can say that you love it. I'm very careful when I say that I love my job, because obviously it's not really an environment that you would say that you love, but I do feel like I am quite passionate about my job, and I feel like I enjoy going to work. Like, I really like my colleagues, I've learned a lot, and I feel like I've progressed quite a lot in my career already. So I really wanted to create this video just to kind of give you all a little bit of a background about kind of what we do on a day-to-day basis and things like that. So without further ado, let's crack on with the video. I really hope that you enjoy it, and please stick around and find out a lot more detail about what goes on in intensive care as a nurse. So firstly, the first kind of pointer I wanted to kind of go around was, why did I choose to work in intensive care? This all stemmed actually from when I was a student nurse. I knew when I was doing my final year of my training that I wouldn't be staying in Newcastle when I qualified as a nurse. So basically a lot of what we could do then as our management placements, people decided to like go into and choose their management placements because they knew that that's where they wanted to work at the end. But I didn't really do that because I knew that I wouldn't be staying in Newcastle, and I kind of just wanted to get more experience on my management placement, and intensive care was one of the places that I'd never tried. So I'm really glad that I actually chose to go to intensive care, because obviously, although I knew I wasn't staying in Newcastle, I kind of found what I wanted to do for the rest of my career then and there, and I knew that intensive care was what I wanted. It really gave me an insight into like what to expect when I qualified, and obviously I was there for a long period of time. Obviously management placement's about 4 months, I think. So I really got to grips with like the routine and what we do and the kind of patients you look after and how sick people get and things like that. So I'm really glad that I did it in that sense. So I guess why ITU for me was because I did it as my management placement. I absolutely loved it, and then when I qualified I knew that I needed to do ward experience first, because I was recommended to do that by actual staff nurses that worked on intensive care when I was a student. They said, go away, go on to a ward for about 10 months up to a year, something like that, and get some experience behind you about just being a nurse, getting your time management right and things like that. So that's exactly why I did that, rather than going straight into intensive care nursing as a newly qualified staff nurse. And I'm so glad when I look back that I did actually do it that way around, because it certainly helped me with experience and time management, managing lots of patients and being more organised and things like that. So I'm really glad I did it that way around. But essentially that's why I've chosen intensive care. So when we moved to Sheffield after Cardiff, I immediately applied for intensive care. I didn't even go for a ward because I knew it's what I wanted, and it was my goal. I wanted to be an intensive care nurse. It makes my brain work. I absolutely love it, and I just felt like I'd found my niche, and intensive care was where I was supposed to be as a nurse. So yeah, that's essentially why intensive care for me. The next pointer I wanted to kind of talk about is, what does intensive care actually stand for? So it's pretty self-explanatory, I guess. So the abbreviations are ITU or ICU, and ICU stands for intensive care unit or critical care. So essentially that's what it is. We look after patients who are level 3. So essentially there are units out there that have got them both combined. So you get your HDU and your ITU. So your HDU would be high dependency, and your ICU is obviously intensive care. So you get places that actually have them combined. So you get like level 2 and level 3 patients, and you look after them both. In terms of where I work on ICU, so it's intensive care. However, we do look after level 2 and level 3 patients, because obviously when we extubate patients and take tubes out, so off the ventilator and things like that, they become a level 2 patient. So we do look after level 2s for a period of time, and sometimes obviously we have level 2 patients admitted, and we look after level 2s just as much as we look after level 3s essentially. Essentially, if you're looking at it as like an outsider, as like without being a nurse or a medic or anything like that, or you're not into medicine in any way, shape or form, you don't work in a hospital, patients that come into ITU are mega sick. They require one-to-one care or one nurse to two patients. Usually for me, I have one patient who is fully on life support, as people like to call it. I absolutely hate those words because there is no such thing as a life support machine. Everything that we do in intensive care is essentially life support. We support every organ as it fails, unfortunately, and there is no such thing as one life support machine. So you know when people say on these TV programs, oh, they switch the life support off, there isn't one thing that's life support. So it's a combination of things that happen when life support goes on somebody. So essentially that's what we do. We support every patient's vital organs. So for one reason or another, patients come into intensive care because one of their organs is failing, or they're in multi-organ failure, or they've been in a horrendous traumatic accident, or they've been into theatre and needed some overnight supervision and things like that. So that's why we kind of that one-to-one care, because that patient is incredibly sick or they require that little bit extra supervision from just one nurse. In terms of like intensive care as well, obviously if you have a relative that's on a ward in hospital and suddenly they deteriorate, they would require coming to intensive care because we actually get the sickest of the sick patients. They require obviously a lot more invasive treatments, invasive monitoring. They may require ventilation, they may require medications to increase their blood pressure. They may need to be sedated for whatever reason. Basically just to require that little bit more support for their organs and things like that. Obviously we do things like dialysis and stuff like that as well. So all of this is done on intensive care as well. So that is kind of like a broad term of what intensive care nursing involves, I guess. But yeah, I'm going to keep going into it obviously in the further sort of topics I'm going to be talking about. But the next one I wanted to mention was kind of like the routine of what we do on a day-to-day basis in intensive care nurse. So I'm going to talk about day shift because nights are completely different. Going on a morning, we get quite a strict and very detailed handover from the nurse who's been on at night, and we also get a handover as a group from the nurse in charge who's looked after, well, overseen all of the patients. But then we get allocated a patient each, and then we're sent away to go and get handover, detailed handover from the bedside nurse, which is obviously myself. I go and get a handover from them, and we'll sit for about roughly 20 minutes and talk through everything to do with that patient, the drugs that they're on, what they've come in with, their family, their next of kin, any communication that's gone on, instabilities that they've got, or how awake they are, or the plans, or any limits that they might have, things like that. That's the kind of detail and depth of things that we go through. We go through things like literally in so much detail because obviously it's so important that we know everything about the person that we're looking after. And then following that, it'll be kind of like time to do drugs and stuff, like 8 o'clock drugs. So people who are on like a lot of regular medications and things are due for like 8 o'clock, 12 o'clock, 2 o'clock, 6 o'clock, and then through the night obviously they're different. So we have like times like that where medications like are due. However, obviously on intensive care people are on continuous infusions of things, so drugs are beeping left, right and centre, and we're changing things around the clock, not just like at specific drug times like you may see on a ward. Obviously we've got like infusion after infusion on mega sick patients, so things are beeping all the time, things are running out all the time. And as a nurse on intensive care, obviously we are required to titrate drugs very frequently and match up the drugs to the observations that we see and stuff like that. So we may need to manipulate and titrate things around very frequently. Obviously then we go on to like our personal care and things like that. So we give patients like a full bed bath. Obviously if they're level 3, ventilated, sedated, requires like a full wash, fully bed bathed, obviously every single day. Sometimes more than once a day because obviously they may well require that. Obviously change all their monitoring around, give them lots and lots of mouth care, eye care. If it's a man, may well give them a shave, brush their hair, wash their hair, etc. Whatever anyone wants individually. Like patients' relatives often bring in like stuff that they wear on a day-to-day basis, whether it be like deodorant, perfume, lipstick sometimes, makeup. Patients like to wear, if they're into that kind of thing, their family will be like they have to have their eyeshadow on or whatever, so they'll bring stuff like that in, and that's the time when we'll kind of put it on, as long as obviously they're not mega sick and require like a quick bed bath, get them nice and fresh, give them all their personal care, and then like have to get them straight back in a comfy position, sat upright for obviously the proper reasons, like for the chest and things like that. That's usually the next step. Obviously we turn patients very frequently, they require obviously pressure relief provided to them. They can't turn themselves, they can't move themselves if they're fully like sedated, ventilated, etc. like that. So we have to do that very, very frequently throughout the day as well. There's obviously then like doctors' reviews, surgeons' reviews. The doctors are on the unit constantly, so they're constantly coming to us with different things that they want us to do. We may well have to do like scans, x-rays, put different lines in, etc. And then throughout the day it's just like sedation hold. Obviously like day to day on intensive care, if your patient's sedated and ventilated, we do tend to do daily sedation holds. So that kind of is assessing patients for how they would be off sedation and how they would respond to having their tube taken out, and whether they tolerate it or whether their observations go massively off and they go massively tachycardic and the heart rate shoots up and the blood pressure shoots up or whatever. We just like to see how they respond, and then depending on that is whether we decide to take the tube out or whether we decide to sedate them again and they're just not quite ready. In a nutshell, that's kind of like how the morning routine goes, and then after that we kind of just wait for the doctors to do the rounds and then for them to just kind of tell us what they want us to do throughout the day, what the plan is, if we plan to extubate, if we plan to transfer them somewhere, if we're going to any scans, if they're going to have anything invasive done, or if they're just going to be a patient that is quite sick and essentially we just need to battle with them all day, keeping them stable and stuff like that. So the day really does vary, and no day in intensive care is ever the same as the last day, ever. So that's essentially the routine. The next pointer is, I guess, why do I like intensive care? Essentially the reasons why I like intensive care is I feel personally like it makes my brain work. Like we get so much autonomy as intensive care nurses, it's ridiculous. Like the doctors have so much trust in us. We're able to titrate drugs here and there. So for example, if a patient of mine was a little bit too awake and they were getting really uncomfortable with an ET tubing, which is essentially the tube that goes down their mouth, which sits in their throat, sits in their trachea and attaches to the ventilator so that we do the breathing for them on the machine. If they're a little bit too awake and a little bit uncomfortable for that, I would turn the sedation up a little bit just to keep them nice and settled. Or if someone's blood pressure's a little bit low, I would start a medication called noradrenaline, which we titrate to maintain a particular blood pressure that a doctor wants this patient to have. Maintain that and change that very, very frequently. And also we administer insulin very frequently, we administer pain relief very frequently. And a lot of these things don't require a doctor to be like, you need to do that. Instead, we use our instinct and look at the numbers and look at blood gases, go and do whatever it is that needs doing. So for example, on arterial blood gases, which we take at least every 4 hours, we would determine if someone needs potassium given, if someone needs some glucose given, if someone needs some insulin prescribing, and we would just go and do it. So for example, with potassium, they often have it prescribed, and if it's below a certain amount, we would just automatically administer it. We don't need the doctor to tell us to do that. It'd just be on our prescription and we just do it without actually asking the doctor about it. So we do have a lot of autonomy, and in that sense I really like it because it makes me use my brain. It makes me think, why is this patient's numbers going a bit, is that correct? Is it accurate? Why is their ECG changing? Why are their SATs changing? Why is their blood pressure suddenly doing that? Is this person comfortable? Are they pain free? And then we have to do like a lot of things like check their GCS, check their eyes, check their pupils, check their movement. And obviously we are like a full advocate for our patients as well. So say for example we're in the middle of providing some personal care or something for our patients, or the physios are seeing our patients and there's obviously a lot of movement going, and yeah, like the patient needs a bit of privacy, but obviously they are sedated and ventilated. So we're kind of the advocates for making sure that our patients are like fully dignified and things like that, so that nobody can like waltz in and see them and open the doors while this patient is being seen to by like physios or whatever like that. It's our place to be like, can you come back in 10 minutes? This person is doing X, Y, and Z. So yeah, I really like it because it gives you the chance to actually provide really good personal care for your patients as well. Like I absolutely love nothing more than making sure that my patient is freshly shaved, looks really nice for their family coming in, because obviously intensive care is a horrible environment for relatives as well as patients. You know that when your family member is admitted to intensive care, they are mega sick, they're on a ventilator, they're sedated, they may be on a dialysis machine, they may be on blood pressure medications, they aren't responding to you, etc. And it's very, very terrifying for everybody involved. So just making somebody look a little bit more presentable, look a little bit more comfortable is actually so much more reassuring for the family as well. So it's really important to do things like that. Yeah, I just really like my job. I feel like it's a lot more hands-on and it allows me to use my brain and actually put my brain to work, sort of thing. The next thing I wanted to mention was actually what skills do you need to develop to become an intensive care nurse. So this is quite easy really to say because obviously it's the same for all nurses, but essentially I feel like to be a really good intensive care nurse you need to be organised, you need to have your time management up to scratch, you need to be quite confident in what you're doing but not overly confident. Like, you need to be aware of who's around you to go to if you have a problem or if you need to ask questions. But you also need to be confident enough to even look after your patient. You don't want to like relatives or your patient more anxious than they are. So being slightly confident around your relatives and things is obviously a good thing. You need to be approachable. You need to be friendly. You need to be sympathetic, empathetic. You need to be good on a telephone because there's lots of telephones and sometimes telephone conversations on intensive care can be super difficult. And you have to make calls to people with bad news and telling them to come in and just kind of breaking things to people over the phone without fully telling them what's going on, if that makes sense. So just simply saying, I suggest that you really come in and see your family member now. They are deteriorating and we'd like to speak to you or we'd like to see you and we think we'd advise you to come in like as soon as possible. So you need to be quite confident in that sense. You need to be well presented, just like thoughtful and be aware of how your relatives are feeling and the anxiety that they've got and the fact that this is a completely strange environment, that we're doing things to their loved one that are completely out of the ordinary and they're naturally going to be absolutely terrified. So I just think it's super important to be understanding of that as well. Yeah, essentially they're all the skills you need to develop or have in order to be an intensive care nurse. I feel there's obviously a lot more out there as well, but just in general I think that is kind of the scope of skills that you need to have. And then finally I wanted to touch on this course that I'm actually on at the minute. So I'm actually on the critical care course, which entitles me to do more as an intensive care nurse than I currently do now. As a pre-course nurse you can do pretty much you can do a lot of things, but until you've done the course you can literally do everything it is in terms of looking after like the sickest of the sick patient. So up until now I can do everything. I can look after level 3, level 2, ventilated patients, sedated patients, patients on blood pressure medications, on various different medications. The only things that I cannot do as a pre-course nurse is look after patients on CVVH, which is a continuous dialysis machine. Can't manipulate ventilators because although I understand what needs to be tweaked, obviously I'm not completely competent at doing that, so that is something that I'll be able to do after I've done the course. I'm also not allowed to touch PCA machines or LIDCO machines, which are very complicated and it would take me far too long to explain them, so I'm not going to do that right now. But yeah, essentially just more invasive monitoring, more invasive things like dialysis I'm not allowed to do at present, but as soon as I finish this course that will be me let loose doing that, which is quite scary, but it's a good step all the same. Really enjoying the course overall. Like, we're doing a really good topic at the minute. We're learning about we've just finished doing respiratory. We currently did cardiac today, and then we've got like lots more coming up, like sepsis, neuro, spinal care, end of life care, nutrition, fluids, etc. Like, it's so good, it's so in depth, and I already feel like I'm learning so much more, and it's kind of putting everything that I knew before. It actually makes sense now, like the actual theory behind it, it's adding up to what I did before, and now it's sort of making sense, if that makes sense at all. I absolutely love it, and it's flying. It's a lot of work, but I am really enjoying it. So I'm super excited for that to be, not for it to be over actually, because I'm really enjoying it. So anyway, I think that should round up my intensive care video. If there's anything else that you wanted to know about intensive care nursing or any specific questions that you have, please do feel free to leave them down below. I hope that I've kind of gone over everything, answered a lot of the questions that have already been left on videos and stuff in the past. But I just really wanted to give you kind of an insight into what intensive care nursing involved. If there's anything specific to do with intensive care that you wanted to know or for me to create another video about, then also leave me any comments down below. Obviously this is what I do for a living, so I'd be happy to do a more in-depth video for people who are looking to do it as a career as well. Yeah, so I really hope that you've enjoyed this video. Please be sure to give it a massive thumbs up for me. If there's any more nursing videos you want to see as well, also leave them suggestions down below. Don't forget to subscribe if you're brand new over here. I create 2 videos a week, Wednesdays and Sundays at 5 PM. Quite often they're a mixture of things like beauty, fashion, lifestyle advice, nursing, travel, etc. So they're not just nursing over here, there are a lot of different other things as well. But yeah, be sure to check back really soon and click everything that I've said, check my social media out, check my blog out, and without further ado, I will leave you guys here. Bye bye! Love you lots! Mwah.